Get ready.
Hi, welcome back. My name's Kaz Riley and this is Trancing in the Sheets. And today I have with me the very wonderful Melanie Majoris, who's a physician and a sex therapist. And before we go over to her, just to remind you that when you join this network, you were sent a $200 gift card into your inbox for travel vouchers. So you can get discounts on the hotels, car hire, and all kinds of cool stuff. So don't forget to go and activate that voucher. And if you'd like to know how travel vouchers can help your business, then just put the word solutions in the box below. So today I have with me Melanie Majoris. She is a sex therapist, a physician. She works right across the board with sexual dysfunction, couples, and some really interesting kind of unusual sexual issues. So we'll go over to Melanie and tell us a little bit about yourself, Melanie.
Hi, Kaz. Thank you so much for having me. I am, as you mentioned, I'm a physician, and I went into clinical work doing gynecology, and in that process, I found a lot of sexual dysfunction, so I became very interested in helping women at that time get through sexual challenges. But in my office practice, there wasn't enough time to talk to them about it, and so when I found sex counseling, that was a perfect fit.
I love that. I love the idea that it's kind of like I need to speak to these people more. You know, that's just a really wonderful thing. So tell us a little bit about your practice, because obviously now it's more of a talking based practice, isn't it?
Yes, so I am an AASECT certified sexuality counselor. AASECT is the American Association of Sexuality Educators, Counselors, and Therapists. And so they have a certification program for professionals who do additional training and then can become certified as a sex counselor. So my practice is entirely sex counseling, and I see individuals and couples, and many of whom are dealing with health-related issues that are impacting their sexual experience or their sex lives directly or indirectly. And so everything from hypertension to diabetes to cancer to all kinds of esoteric genital related conditions that then cause sexual challenges.
Okay, so tell us a little about the process that you would take a person through or a couple through of what would they expect if they came to see a sex therapist?
I'm not sure 100% what they might expect with somebody else, but for me, I like to talk to my patients one-to-one or one to whoever the patients are. So if it's a couple, so I don't have any paperwork that they fill out in advance. I get their history, much like a physician. I get all their different categories of history, their medications, their history of surgeries, their history of injuries, all of that, all before we even talk about sex at all. And then I ask them, after I get some family history, some counseling history, I ask them what brings them in, so that they can give me in their words what it is that is important to them to work on. And then I sort of probe into that issue a little bit more. And once I get the understanding of what's happening, then I do what's called a sexual status exam, which is where I go and ask them very detailed questions about their sexual experience. If they're an individual, then it would be their standard sexual experience. If it's a couple, then it's with their most typical sexual experience. Okay. And I might say, tell me what happens from the start to the end. When do you find out you're going to have sex? What does the sex start to become? How does it develop? What happens? And I ask them as if I'm a fly on the wall and you're doing a choreography, tell me what happens. And so I will stop each of them at different spots in the story and say, and how did you decide that you were going to move your hand from her breast to her genital area? How did you decide that? And he's like, well, she seemed happy, so I did. I'm like, okay, but you made that decision. He's like, yes. And that's for the first time, the woman is like, oh, he's making decisions in the process of feeling good. And so it really helps. And then other times there might be, well, we start kissing or we don't start kissing. And I say, well, do you like that or do you not like that? Or does that feel good or does it not feel good? And sometimes you get some interesting answers because there's an assumption that things feel good when sometimes they don't.
That is so interesting, isn't it? When, I'm guessing that probably right in front of you, if you're doing that together, they're communicating properly for the first time about their sex lives, because people often believe that they're communicating well, don't they? And not very often they're not, are they?
Right, exactly. Exactly. It's very eye-opening for both of them.
So yeah, so I can imagine that, just actually that consultation process is actually a massive part of not only you understanding what you're working with, but them understanding what they're working with. When you're what kind of sexual dysfunction do you see the most? Is there anything that you see more than anything else, or is there a kind of a range of things that you see?
There's always a range, but pelvic pain tends to bring people into the sex therapist pretty directly.
Mm-hmm.
I work with excellent sexual medicine physicians and also excellent physical therapists who specialize in the pelvic floor.
Mm-hmm.
And I see couples and women, usually the women are in couples, and they have maybe what's called vaginismus,
Mm-hmm.
which is where the vagina basically snaps shut. And does not allow penetration. And that can be very surprising for people who have waited until marriage to have intercourse. And so I end up seeing both of them. And the husband is like, this was supposed to be different. What's happening is supposed to be natural and easy. And I'm like, yeah, if it was so easy, I wouldn't have a job. So it's not, it's one of those myths. And then other times I see men who have pelvic pain, which is very under discussed. And they go to pelvic floor physical therapy too. And they have reasons to have pelvic pain that impacts their sexual function that sometimes they don't even tell their partners. And so I'm like, I have to normalize it, give them permission to be somebody who has a medical pain problem. That doesn't mean anything else than they have a muscle or pain problem. So working with those individuals on the anxiety and the poor coping mechanisms that develop as a result of the pain and the avoidance of sex and those patterns is really, really important so that we can reintroduce sex as a safe place for them.
It's amazing, isn't it? That fear, tension, pain cycle that once people get into that kind of cyclical reaction, it just gets stronger and stronger until something or someone comes and intervenes with that, isn't it? Yes. They just kind of get to the point where they believe that's the way it's always going to be, which of course it doesn't have to be, does it?
No, it doesn't. But it is the most natural thing.
Yeah.
Right?
Yeah.
That pain, tension, avoidance cycle.
No, absolutely. It's there for a reason, but it's not always helpful. That's it.
There's times to find a new pattern.
Okay. Now I know you work with all the usual things like erectile dysfunction and all that kind of stuff, but there are kind of sexual issues or conditions that are actually quite rare, but not quite as rare as people might think, aren't there?
Yes.
Tell us a little bit about those, because I know that's a real speciality of yours, is dealing with some of those, isn't it?
Yes. So I can't speak to how rare or not rare they are. I think they're underdiagnosed in general, and I may not be able to capture all of them here. But there's one or two conditions that are really interesting that might be helpful for people to know that exist. One is called persistent genital arousal disorder. Mm-hmm. It has a rather unfortunate name, and I think in the next several years it will be renamed. But persistent genital arousal disorder is unwanted physical sensation of arousal of the genitals area. This is unprovoked, uninterested. These people, many times women will experience this with a great amount of distress because they will have that, as you get close to orgasm, there's that moment where it's like pleasure, but also pain. Mm-hmm. It's like they're living on that edge all the time. So they have an incredible urge to masturbate, and that gives them partial or zero relief. And so these women may be stuck in bed, like basically masturbating all day, and it appears that they have a mental disorder, but actually they have a physiological, neurological problem that has been shown that responds to some neurological interventions, such as injections and other types of things. Where it comes from and how it develops is a little bit different in everybody. There is an association with anxiety, but it is different for everybody. So for example, I have one patient who I actually saw when I was doing gynecology, and she was in her 60s, and she described having these sensations that came and went. So it was there, but it wasn't persistent, constant. Mm-hmm. And she talked herself or relaxed herself out of it. So she identified that if she did some deep breathing and relaxation and meditation, it would go away. And I'm like, yes, that's great. So she had a pretty mild case.
Mm-hmm.
Other individuals have a spinal abnormality. They have some cyst or something that's pushing on one of their nerve roots, and it's activating that nerve that is supposed to feel those things when you have like touch, when you have sensation, but it's overactive nerve. And so those people may need more sort of interventions rather than just relaxing it away. But relaxing helps, but when you have this sort of constantness, it's a lot. So that's very, very difficult problem, and it results in a lot of suicides.
I have seen that actually. I've had a couple of clients with that particular disorder, and you know, the effect that, or the impact that it has upon their lives is massive, isn't it? It's not, you know, and you know, people talk about, you know, it's one of those things that's kind of almost jokey, isn't it? This kind of persistent arousal. But actually, if you're the person that's in a state of persistent arousal when there's no relief, it's not even like a desire to have sex. It's just this sensation that's distracting, you know, can interfere with work, interferes with relationships. And of course, people get very anxious about it because it's a sexual thing, or seemingly a sexual thing. There's all the shame and the guilt in there as well. So they get even more anxious about it as well. So there's, you know, and you can see how something like that maybe isn't as rare as we believe it to be. It's just that a lot of people suffer in silence with it because they're ashamed, aren't they?
Yep. I actually have a male client who has it as well, but he didn't know he had it until he came to see me, because his whole life he's just been ready to go with erections. And he said he wouldn't even have to think about it and it'd be there. He remembers being 5 years old and 6 years old and being embarrassed about erections. Now, 5 and 6 year olds do have erections, but they don't usually have them while they're playing with their friends, that where is such a situation would be embarrassing. So he remembers that. And he remembers masturbating hundreds of times a day, and thought that since this, we have a stereotype that men always think about sex and that men always want sex. He thought that was normal. And so now in his 30s, he's having changes in his functions, which again are probably some you know, progression of whatever condition was causing this to start with, something spinal maybe. And so he's all like, "What's wrong with me?" I'm like, "Well, you had a condition that wasn't as normal as you thought it was, and that was nice for you at the time, but he didn't identify it as pathological." And I think largely because he was male.
This is the thing, isn't it? We have so many stereotypes and myths around sex that actually can stop people from being diagnosed with some of the things that they need to be diagnosed with and get help with, so that they can actually have a really satisfying sex life. Because what this stops people doing is having that connection and satisfaction quite often, isn't it? It's causing issues, and they're just something that they've kind of either learned to live with or they're too embarrassed to talk about. And actually, you know, it's often fixable, isn't it? You know, that's the thing.
Well, it's workable at the very least. And so my motto is, in terms of sex, it's dynamic. And so you have to expect it to change over the lifespan. It's not going to be static. It's not going to be staying the same. I remember I had a couple and he was trying to see if they could fix their sex life before he proposed. They'd been together for 5+ years. They owned a house together. They had animals together. And I said, well, you know, you could wait until everything is perfect, but I guarantee you that after you get married, it will change and become different. So you probably would do better looking for somebody who's willing to work on this and identify it as a priority, more than finding the perfect person before committing. And so yada, 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 they're married and they're doing great and they graduated. So, you know, from my program. So, you know, that kind of a thing where you recognize the importance of sex, but also recognize that it will change over time. And that when your health and your personal space and all of those details that come with aging change, it's okay that sex changes. And when it changes, you can find new things that make it even possibly better than it was. But at the very least, it will be different.
It will be different. And as you say, often better. I know, speaking, you know, age often helps to improve sex, you know, longevity of relationships can they seem to either it gets better and better or people stop doing it. And that's a whole different thing. And of course, there's things like there's some of the myths around, yes, you know, female bodies change and you know, as we go, say, through the menopause, but for a lot of women, that's a time of liberation because they're not worried about getting pregnant and all kinds of stuff as well. You know, they don't. So it really just depends on the person as well, and the relationship and the dynamic, how a relationship changes, I guess, through lifetime, but also how personal sex changes, you know, preferences and people's minds expand and then you find new things and all kinds of wonderful things.
Absolutely.
So one of the other things that I know that you work with, there's a lot of focus on orgasm, isn't there? In, you know, when we talk about sex, and, you know, and things like anorgasmia get a lot more press time than they used to be. But actually, something that a lot of people don't know about, that for some people, having an orgasm can actually make them feel really ill, can't it?
Yeah. Yep. That's called post-orgasm illness syndrome, or POIS for short. It's very poorly understood, and it has a wide variety of different presentations.
Mm-hmm.
So I have one client who, after every ejaculation, he will feel like flu-like symptoms for 4 to 7 days. And if he doesn't have ejaculation in 1 to 2 weeks, his body will create an ejaculation during the evening. So he'll have a nocturnal emission without masturbation. And that's not particularly unusual. That's within normal range of that nocturnal emission. However, if he has the nocturnal emission, he still gets the post-orgasm illness syndrome. And so finding a medication for him so that he can basically masturbate in peace is sort of a goal. And there's a bunch of different ones to try, which again, I'm working with a sex medicine doctor on that, but none is really known or proven. And so it is kind of like the wild, wild west of medicine. Like, we're learning more about it every day. But you can imagine how that would impact his desire or his comfort in pursuing a relationship.
Oh, and his life as well. I mean, if you spend, you know, probably 2 weeks out of 4 with flu-like symptoms. I mean, if you were not talking just a cold here, we're talking aching body, aren't we? And, you know, the whole shebang, really. Simply because you had an orgasm, you can imagine the association between that. It's ejaculation, isn't it? Really, I guess. Is he able to orgasm, or people like that? Can they learn how to orgasm without ejaculating, or is it to do with the brain chemicals? So that, you know, how does that work?
Well, he is interesting because he has a couple different conditions that are layered on top of each other. So he also has exercise-induced orgasms, which are within the normal range as well. Men and women have them, and they are non-problematic if they don't bother the patient who has them. But in his case, he will have a non-ejaculation orgasm during exercise, and that will still result in the POIS symptoms.
Wow.
So it's really challenging for him. So one of the goals was to get him to find a medication that took the edge off some of those symptoms, because we can't know exactly what it is that's doing it. So we can't necessarily say this will definitely work. It's more like, you know, trying to figure it out. And that would allow him to exercise, but then it gets a little muddy with him. Other people have different symptoms. Some will have dizziness. Some will have headaches after orgasm. And if it's a woman who says that she has orgasm followed by a headache, she may not be believed, you know, because it's one of those sort of classic tropes that a woman has a headache and doesn't want to have sex, you know, which again is a stereotype and not necessarily based in reality, but that's what we are living in, systems of belief in our world.
We are. And from what you see, I mean, you obviously work right across the board with all kinds of sexual things, whether some are medically caused, some are psychologically caused. How much do people's beliefs about sex play into, you know, the kinds of dysfunctions that you see?
Oh, it's massive. And that's one of the benefits of working with a couple, because when I was working as a physician in the gynecology office, I couldn't access the other partner and their beliefs or false beliefs. But in the therapy room, I can access both and address them both. So I had a lovely gentleman come to see me, and he had been married for 10 years. He was in the prime of his life, and he said, I have erectile dysfunction. I have performance anxiety. And I said, okay. And so I started talking to him about, you know, well, his wife wasn't there, and would she be willing to come in and this, that, and whatever. And of course he's like, yeah, but you know, this is really it's my problem. And I said, okay. So as I got through the story, when she did come in, it was actually that when he would have a loss of erection, she would run to the bathroom crying because of what she believed it meant about her.
Yes.
Right. And so that's where her belief system impacted his sexual experience and his feelings about himself, because, and it was her feelings and beliefs about her body that she had some concerns that if her partner had an erection and would have sex with her, then she was adequate. She was attractive enough. And if he didn't have an erection at all times, then there was a problem and he didn't find her attractive, which was not true. And so it's not true for most men. In fact, men, they're not machines, right? The penis,
absolutely.
Penis goes up, penis goes up, penis goes down, penis goes up, penis goes down. It's just how it is. It's, human nature, and it's how the body works, and it's okay.
That's certainly something I see here a lot, actually, with erectile dysfunction, where often it's just normalizing what's actually happening to them. So they'll often say, well, I'll get an erection and then I think I've got to get on with this as quickly as possible because I'll lose it. And I'll say to them, but it'll come back again.
Yeah.
Oh, but what if it doesn't? And I was like, you're not supposed to have, if you're being intimate with somebody for a long period of time, you're not supposed to have a really hard erection for
the whole time,
3 whole hours. That's not how it works. Arousal doesn't work like that. But people have been kind of taught that's how it works, haven't they?
Yeah, that's the expectation.
And it's right in there. And it's and similarly, some people, just, are responsive rather than, rather than the people that will instigate. And that's sometimes just that's how they work. They're just, somebody will do it and then they'll think, oh, that's a good idea. And they'll respond, but they're not necessarily an instigator. And then they're with somebody who is an instigator who, feels terrible that the other person doesn't want to do that, when in fact they do. It's just about understanding the dynamics within a particular relationship as well, isn't it? And of course the women that have vaginismus that actually do feel arousal. That's a really interesting one with vaginismus, isn't it? They often have a really healthy libido. It's just the ability to kind of be penetrated that's the issue. And then of course it's that fear, tension, pain cycle again, and then we get into avoidance again, don't we? And that's what happens. All of these things.
And their libido goes down.
Yeah, leads to avoidance, and then the libido goes down, and then it all goes to shit, really. So that's
yes. And so much shame. So much shame.
This is the thing, isn't it? And if we could get rid of that, and perhaps, and it is some of those beliefs, isn't it, where sometimes we do get people who have waited till marriage, and there's nothing wrong with that if that's somebody's belief system. But then the belief system is that it'll all be fireworks and wonderful and amazing. Well, of course, you have to learn how to have good sex, don't you? And learn that within that particular relationship as well.
Mm-hmm. Absolutely. Absolutely.
So how do you help people do that in terms of just learning what good sex is? Because a lot of it is about challenging those beliefs. How do you go about doing that with couples?
I usually start with some version of Sensate Focus, which was created by Masters and Johnson in the 1950s when they did their research on sex. And so it's basically reintroducing touch in a safe way that doesn't mean something. And I give each partner a timed opportunity within homework that they do at home to feel their own body and what it feels like for their own body to be touched, and also what it feels like for their own body to touch their partner in very structured, organized exercises. And I do that because, we will discuss and collaborate on which parts of the body are allowed to be touched and what types of touches are going to be most reasonable to do. Because some people are very ticklish, and I will give guidance about how to touch somebody who's ticklish, because we are trying to reduce anxiety, not increase it. So that, we work on those details that are specifics, but the big picture is that we are getting them to learn what touch feels like to their body, touch that's safe, and let that become a positive, a neutral or a positive thing instead of an anticipation of a negative thing. So I try to disengage the anticipation part by taking sex, off the table for those exercises, and sometimes in total, depending on the situation, and trying to gain their ability to be mindful and focus on that. And then when they come back after they've done these exercises, I talk to them in detail about what did they notice. What did they find? What didn't they prefer? What did they prefer? What were they thinking when they were touching their partner? And almost 100% of the time, they're thinking, oh, I hope that my partner likes this. Are they responding well? And I'm like, no, this is not about pleasing your partner. For once, when you're touching your partner, it's actually about you. It's about you feeling your own body and doing what your body wants to do in terms of touch. Yeah. And that's really empowering, So giving them some empowerment is sort of my big time goal.
Absolutely. Well, it's permission for pleasure, isn't it? People don't do that. They'll often give themselves permission to give, but not to receive. And of course, one of the most pleasurable things for somebody is to know that somebody else is having pleasure whilst they're with them. So you kind of get this wonderful feedback pleasure loop going that then is a positive thing rather than this kind of negative, doubt, shame ridden, all kinds of stuff thing that's full of anxiety. And sex and anxiety just don't go very well together for anybody. It affects,
they really don't,
hormones and everything. So
no, everything goes down.
Literally.
Yes.
So, I know. So sadly we're out of time. I told you it whizzes by these interviews. I am hoping that you'll come back and speak to us again, because I know you work with some really interesting things. You've got some really wonderful methods. I know your practice is busy. I know we had to, it took us a month, didn't it, to just to organise being able to chat for just for 20 minutes. So so if people want to find you and more about you and what you do and your work, where would they go? Where would they look?
Well, I'm based in the Metro DC area, and my website is www.sexualhealthconsultants.com. So it's all one word, sexualhealthconsultants.com.
Okay.
And it's just, there's, my information about me. You can reach out by email that way. And that would be the most effective way to reach me. But you can also go to the AASECT website. So that's AASECT, AASECT.org. And that website has a list of professionals who have been certified by AASECT as sex counselors and sex therapists. And you can search for your area in that directory. And that way, who's been qualified to do sex therapy and sex counseling. So they would be people who have high ethics and people who have good experience and enough education that they would be a great place to start too.
That's fantastic. So even if they can't come to your area, they'll know where to find one in theirs, if that's the case, which is that's wonderful. Thank you so much, Melanie, for coming on and sharing just some really cool knowledge and to kind of really help educate people, because I think people often accept things as being the norm, or they're too embarrassed when they need help, especially around sex, to go and ask for it. Excuse me. So I think just a lot of that knowledge may help if it just helps one person just to go and seek some help if they really need it, or for a therapist to recognize something that maybe they that we've not heard about before. Then that's truly valuable. So thank you so much for being here.
Thank you so much for having me. I really appreciate it. And definitely, the more people who know that sex therapy exists and there is help and there is a better option for you if you're unhappy or nervous about sex, the better.
Absolutely. We keep doing our thing, don't we?
Yes.
So if you're enjoying Trancing in the Sheets, then come and have a look at some of the other episodes. We've got all kinds of things on this show. We've covered erotic hypnosis. We've looked at kink-friendly hypnosis. We've had wonderful physicians on like Melanie, and a whole host of other stuff as well. As lots of you know, I teach the Sexual Freedom Hypnosis Program, which you can access at sexualfreedomhypnosis.org for all the latest training dates and venues. And we've got an online course coming on soon. So thanks for joining us, and I'll see you next time on Trancing in the Sheets. See you later.
Get ready.